Hello and welcome back to LTC Heroes Live by Experience Care. My name is Peter Murphy Lewis. I'm your host. I'm excited because I'm talking to Dr. Priti Jindal. She's the Chief Medical Officer at Transitional Care Physicians of America. And the reason I'm excited, and I shared this with her right before we hit record, was I love talking with chief medical officers. I've only spoken to one or two, and I also have never spoken to anyone who's kind of a guru in transitional care. So, with that introduction, welcome to the program, Dr. Jindal.
Thank you, Peter. So happy to be here.
Dr. Jindal, tell me about when you got into long-term care, and feel free to get into the details of the acute to post-acute learning curve, because I was going through my notes and I know that caused you to giggle when we first asked you that question. So I'll let you start there.
Yes, absolutely. Well, I started as a hospitalist in internal medicine. I worked in acute care. I was taking care of patients coming to the hospital in congestive heart failure, pneumonia, sepsis, requiring ICU care. So it was very critical, very much acute in nature. Um, about 5 to 7 years after I was in acute care, I was introduced to this excellent geriatric practice in Austin, Texas. And I started working in long-term care at that point. At first, I just wanted to try it out because frequently when I worked in the hospital setting, I would see a lot of older adults, seniors come in, which I feel like they really needed more attention. I feel like they needed their medications more closely looked at. Providers, physicians needed to speak with them more about the goals of care, about their overall care in general. So when I transitioned to this geriatric practice, I started a couple days a week, and then I just loved it. I found it was my calling. I found that there was this very large population of older adults living in long-term care facilities, very much in need of increased attention, increased care from physicians, from providers. And at that point, I never looked back to acute care or the hospital setting. I transitioned to long-term care, and I've been there ever since.
Now you still practice today, right? A couple days a week.
Yes. Yes, I do. I absolutely do. So after I transitioned to long-term care, I was 100% practicing. Then I was offered the chief medical officer role for a large senior living provider. But my one condition was I will take the role, but I want to keep practicing. I get so much reward, joy, passion out of the direct one-to-one interaction with my patients, the families that I see. So I continue to do that 1 to 2 days a week.
Tell me about that learning curve when you transitioned into the CMO of a large organization. And correct me if I'm wrong on the numbers, 280 facilities, 26 states.
Yes, absolutely. About 25,000 residents at the time.
Were you
Yes.
scared? Were you nervous? What was
I absolutely was scared. They really took a chance on me. I think I was the medical director of one of their facilities, and they offered the position to me, and I was very excited, a little reluctant at first because, as I mentioned, my passion was really the one-to-one patient care. But I saw this opportunity as a way to improve care, clinical programming, clinical processes across a large population of older adults. So I did accept the position. It was a very, very steep learning curve. As you're likely aware, there's a business side to long-term care. So I learned so much from this organization about the owning and operating of large, long-term facilities across multiple states, how to create clinical protocols across so many different facilities, how to improve care overall. So it was a very steep learning curve. I served in that position 5 years, and I'm very grateful for that time. I learned so much about that side of the business.
Tell me what advice you would give to your younger self, right? When you accept that position, maybe it's a month or two away before it actually starts. What advice would you give to the younger Dr. Jindal about the business side, about leadership, about HR, about your time, about how your framework for approaching problems?
That's a great question. So, at the time I did speak out to other experienced chief medical officers of similar senior living operators. They were very helpful. I think I probably should have spoken to at least five more to get their experience. I think I spoke to two, but that was incredibly helpful. And then I think it also would have helped to speak to more operators and understanding how do you run a large senior living operation like that, because there really is a business side of things. And, although, I would love to just wave a magic wand and put out there all the clinical programs, without concern to occupancy, financial impact, or anything like that, I think it would have been more helpful to speak more with other operators of senior living organizations.
Are there elements to that new role and that leadership role that 3 months or 6 months into the job, you're like, I'm not going to master this. I'm just going to trust my team, or I'm going to delegate to someone who understands this way more than me, and I'm okay that I'll never understand it.
That's such a good question. Yes, absolutely. There were some aspects of the business that I just said, you know what? I'm going to acknowledge I don't know anything about this, and that's fine. I'm good with that. With such a large organization, I very much heavily relied on multiple different departments, health and wellness, the physical therapy department. But luckily, we all worked very, very well together. So likewise, when they had certain clinical areas, especially, for example, during COVID, where they needed my help, and my insight, I was happy to provide that. And likewise, there were multiple different areas where it really wasn't in my wheelhouse. And, medical school didn't train me or anything like that. So I was happy to let that go as well.
Dr. Jindal, tell me, what is your role at Transitional Care Physicians of America? What do you all do? How big are you? A little bit of your history.
Absolutely. Thank you. So I just joined this organization, TCPA, about a year ago, initially as a practicing physician. And what we are is we are a very large post-acute care practice in the state of Georgia. We are the largest post-acute care practice in Georgia. We take care for about 3,400, 3,600 patients who live across various long-term care facilities, assisted living, SNFs, skilled nursing facilities, as well as independent living. And it totals about 110 facilities in the state of Georgia. And so it's a bit different. We're not owners or operators of facilities. We are a practice. So we employ physicians, nurse practitioners, psychiatrists, geriatricians, nephrologists, all different types of clinical care providers. And we send those providers out to facilities to help with resident care, taking care of the residents. And the reason we're called Transitional Care Physicians of America is because we help with those transitions. For example, when a senior resident is being admitted to a skilled nursing facility, or a resident is currently living in assisted living facilities and they're declining and require admission to hospice, those are the type of transitions that we take ownership of. We help the facilities, we help the patients, we work with the families as well to help with those transitions and improving their care.
I'm a little bit, I guess word is not confused. Could you clarify, if you currently don't exist in someone's kind of care spectrum, how are they fulfilling that transitional role? And then answer to me, at what point does someone raise their hands up and be like, we can't do this in-house. Let's call Dr. Jindal and have her team do it.
Yes, absolutely. So we serve essentially as primary care physician and the primary care provider for all these residents. So that's basically how we help with the transition. If a resident's admitted to a skilled nursing facility or an assisted living facility, we come in, we evaluate the resident, we order all their medications, we order appropriate laboratory tests, we see them in person, and we assess them right there at the facility. So that's essentially how we help with transitions. And as you mentioned, if anything goes wrong with any of the residents, patients, say they have a cough, they have an issue with their medications, families have questions, that's when they call like Dr. Jindal or any one of our other many providers to go in, do a visit, see them, and help with that transition, help with their care.
Can you speak to me, and this is a very personal question, speak to me about why you wanted to take on this challenge in this new role? It's because it seems like you went from, I guess you jumped from one niche of post-acute care over to another. I'm interested, were you looking for the challenge? Was it challenge plus you felt like this needed to be improved drastically? Was it a friend who called out and said, hey, we need someone like you, and you're like, you did a personal favor? Walk me through what was going through your mind when you took on this new role.
Yes. Well, as I mentioned, I was in the previous role for 5 years, and that was working for a owner operator of senior living organizations. I decided for my next career path, I wanted to work directly with a medical practice. So a practice that employs physicians, nurse practitioners, who has a direct impact on clinical care. So that was what I was looking for my next adventure. I feel like as the CMO of a practice, I could have a larger impact on direct patient care. Said if that makes sense, and that's what I was looking
Sure.
for my next adventure, and work, and especially working directly with physicians and providers like nurse practitioners who care for this population, because I feel so passionate about improving their care, improving the quality of their care, having them live as long as possible in their current facility, without winding up in the hospital, without winding up on 20 medications. That is what I want to work on and improve in that space.
So break it down for me, Dr. Jindal, in kind of layman's terms. What what does your current job look like? So like say that there's I'm a CNA. Let's say that there's 10 frontline caregivers in front of you and they're like, "What do you do today? Tell me what you do, but also answer kind of as part B of that question, what's your favorite part of the job? What's your favorite moment in the week?"
Oh gosh. Well, why don't I tell you about my day today? Because my day is not typical for a typical provider in this space. Since I have a CMO role and I'm also a practicing physician. But I woke up this morning, I got my white coat, my stethoscope, my blood pressure cuff. I drove to a lovely assisted living facility that's about 30 minutes from my house. I went in, I talked to the executive director as well as the wellness director who work at this facility, and talked to them about all the residents who I'm seeing today, any issues they may have. Then I go one by one to every single resident, examine them, talk to them, review their medications, and then I do my charting. I send orders. I call families and talk to them about their care. So that was the first half of my day. Then for the CMO stuff, I come back home. I jump on a couple of virtual calls with some facilities in Southern Georgia, participate in their QAPI events. I interviewed a couple of nurse practitioners for possible roles for their organization. I reviewed with our operational team how we're currently scheduling visits with residents and how we can improve that. So it's a bit of a mix and match, but that would be a typical day for me, a combination of patient care as well as CMO work. And in terms of what's most fulfilling and what I enjoy the most, and I would have to say that the patient care gives me the most satisfaction when I feel like I made an impact on one of my patients' lives, really improved their health, improved their comfort, improved them and their families' day-to-day life. That's incredibly gratifying, and that gives me the most joy.
My follow-up question, I think, is pretty close to what you just stated there. And I asked you before we went live, I said, what's something you're passionate about that I might not ask? And you said, oh, it's definitely talking to family members about quality of care. This is kind of a weird question, I think. How do you get out of the acronyms and the jargon that we have in long-term care? I know when I first got into long-term care about 3 years ago, I didn't even understand the word quality of care. And then people in this industry say deliver care. If you talk to a 55-year-old who's bringing their 85-year-old mom in, I don't know if they use those verbs. So talk to me about how you take off physician's hat when you're in the CMO role, and then when you're in practice role, how do you become the human who's explaining to family how they can ask about quality of care, how they can demand quality of care?
That I love that question, and that's because it is incredibly important to be able to speak in a language with your families, your patients that they understand, and get rid of the jargon. And so, the way I like to explain that is, after I have seen one of my patients and I'm speaking with the families, I just generally ask the question: how can we make your life better from a medical point of view? How can we make you more comfortable every day? How can we reduce the total number of pills you're taking? In my opinion, no 95-year-old should be taking more than 5 pills a day. And what can we do to reduce that amount? So, I think by listening to families, listening to patients, and understanding what their concerns are, and then reacting to that, addressing their concerns in language that they can understand is incredibly important. So I don't know if that answers your question, but I think that's basically my method of how I do that.
You did, just by using the way that you use the phrases. I wish that I could have read, like, there was a book that I read, like learning long-term care quickly or something like that. I wish I could have read that dummy notes written by you, so I could make sense of everything when I was getting into it.
That is so nice, because I have to tell you, at least for physicians in the medical world, there is no training for long-term care either. All the jargon, you ask any medical student, what is a sniff? They would have no idea what that is. And so I agree, there needs to be some kind of manual or cheat sheet for long-term care jargon.
In kind of piggybacking off that, last week I was at a convention in Chicago for the Health Information Technology HIMSS, and almost every vendor I went up to, none of them even knew what long-term care was. When I said post-acute, people didn't understand post-acute. I always had to say nursing home. So instead of trying to sound like I'm the important person and ask people questions they don't know, I just went straight with nursing home. Oh, no, we're not in nursing homes. And I'm like, oh, because there's not enough money. Yeah. To be honest, I'm not being recorded, right? Yeah, there's not enough money. I'm like, oh, gosh, this is sad.
Oh.
Dr. Jindal, I want to ask you about your mentors. You spoke when you first got into healthcare, and when you got into long-term care, you had some important mentors. If you feel comfortable, share their names, and what did you learn from them?
Absolutely. So when the geriatric practice that I mentioned earlier in Austin, the founder of that, her name was Dr. Peggy Russell. She's amazing. I believe she's retired now. She's a great geriatrician, and she had a partner, Dr. Liam Fry, another geriatrician, and they showed me how you do a proper geriatric visit, how you see an older adult, what you do during that visit, how you communicate with the family, what you accomplished at the next visit, and so on. So I learned so much from them about geriatric care, and how to run a geriatric practice properly. So that was my initial introduction. I absolutely would say they were my mentors. And I think if I hadn't had that exposure to that excellent geriatric practice, I probably wouldn't have gone into long-term care, because they really showed me the beauty of it and how rewarding it can be. And then later in my career, I joined the American Medical Directors Association, AMDA. And so I'm not sure if you're familiar with this group, but it's a group of all physicians and nurse practitioners, providers in long-term care who serve as medical directors of skilled nursing facilities. And this group of professionals is incredible, absolutely no ego. And everyone in this group really cares about long-term care and seniors. And everyone is in it not for the money, not for any accolades or rewards. They're in it because we all just really care about improving the lives of older adults, residing in long-term care. So every time I go to that conference every year, I'm just so excited just to be surrounded by so many people who share the same passion, and all of the topics, the sessions, all the education is exactly the topics that I'm interested in, that I feel help me with my current role.
My next question for you, and I think it's related to mentoring, but maybe not. And I should admit right away, it might be very, very ignorant. It has to do with ongoing learning. I have a sense that, for MDs, or even those of us that are in social work, so I come from the social work world, I feel like there's a lot of learning curve at the beginning, but then afterwards, the ongoing learning, or the resources that you turn to, you get in the street, you get doing the real work. Mm-hmm. If that's not true, where do you turn to when it's turn to learn? Do you go to conventions? Do you go to those mentors? And feel free to get into the details. Like, I call this person whenever a new policy comes out, or I call this person whenever I have a new KPI for the next year and I don't know how to get there.
Yeah, another great question. Learning is so important. The older you get, the more experience you have. I think you're right. It's so easy to just get in the day-to-day routine. It's incredibly important to keep learning, stay up to date on all the materials. And I do that in multiple ways. And one of my big roles as CMO is clinical education. I'm responsible for the clinical education of all the physicians and providers in our organization. So even more reason it's important for me to stay up to date on everything. And just to give specifics, as you mentioned, there's a great resource called Up to Date, which is, which all of us have this app on our phone. It's a way to look up information very quickly and stay up to date on the latest research. I listen to all kinds of podcasts from all different, different organizations, such as Long-Term Care Heroes. There are many medical podcasts, specifically dealing with geriatrics, psychiatry, neurology, rheumatology. It's one of the things I do when I drive. I listen to podcasts and then I educate others later. Grab some water.
No worries. And feel free to name some more if they pop up, especially in the next question, which is I want to ask you what advice do you have for family members around transitions?
Transitions are incredibly important, especially for the older population, for seniors. It's very difficult. A lot of seniors are so used to living in their current home, their current environment, sometimes for 20, 30, 40, even 50 years. And to take them out of there and put them somewhere new, they need a tremendous amount of support. So number one, for families, I recommend make sure you understand where they're moving. Make sure you tour the facility with your loved one ahead of time. Make sure you get to know all of the staff, the director of wellness, the executive director, social worker, activities, so that at least when your loved one moves in, that they're familiar with all the staff that work there. And then, after you move in, make sure, the belongings, pictures, photos, memories, furnish their apartment, their residence with, items that they're familiar with. And then, after they move in, check in frequently. Make sure the medications are being prescribed as they should be. A lot of times with transitions, the medications always get messed up in terms of timing and when they're prescribed. I recommend actually checking out those medications, the MAR at the facility, make sure they're being given appropriately. Make sure that the staff is aware of everything going on with your loved one. When do they eat breakfast? How much did they eat for meals? Are they participating in activities? Do they go to bingo every night, or do they go to exercise therapy? And if you notice with the transition, if you start noticing, little things, personality shifts, weakness, not walking as much, that's a perfect opportunity to intervene early. Let the staff know, let your loved one's provider know. And there's a lot more that can be done to improve their life.
What are the kind of following up on the same question around advice? What are the one or two low-hanging fruit for family members that will have great impact, little effort from a family member that we don't remember all the time? Maybe we don't remember because we're stressed or because there's a lot of family discussion or debate or criticism going on, or from fear of what's going on those last moments. What are one or two simple things? Start with this instead of a list of 10, and this will have a large impact.
So I would say one of the biggest contributors to patients not doing well with transitions is the social isolation and not being around anyone they know. A lot of times, a family member will move someone into a community, into long-term care for the company, but sometimes the patients just stay in their room all the time. So, a very easy way to check to see how they're doing is asking the staff to give them a diary or a log of what did my loved one do all day. That would be a very easy way to keep tabs on how they're doing. If they stayed in their room all the day, just came out for meals, or stayed in their room for meals as well, that's a red flag. And that's one way that red flag telling you need to intervene early and get them out of their room more, get them involved in activities, come up with a care plan with the facility staff so that they can actually, do something to make them more socially active.
I like that. That reminds me, I guess it's not 100% along the list of kind of activities, but when my grandmother, I feel blessed that right before I moved to South America when I was 22 or 23, my grandmother transitioned from home into kind of assisted living, and she had a little bit of dementia. She was pretty functional. She had a little bit of dementia. And I don't know if it was my father's idea or the administrator's idea, but they said, hey, can someone from the family just come and sit with her every single day, help her unpack the bags, and watch her favorite movies? And I can remember watching old Westerns with my grandmother, watching them a day or two before we moved out of her house. And then when we moved into her new room, we watched them again. And I think that transition helped a bit. Obviously, we did the normal things of hanging up paintings that she would remember and family pictures, but kind of old movies, especially that she would remember because of dementia. I feel like that's kind of in line with your list of daily activities.
That's a great idea. And I actually have a resident right now, a patient of mine who lives in assisted living. You walk in and he's got a big bookshelf filled with DVDs, just
Mm.
so many just different DVDs to watch. And I think those movies really bring him comfort. He does stay in his room all the time, but he enjoys those movies. And he always tries to lend me a few every time I go in there. Where the Crawdads Sings, that was the last one he wanted me to watch. And I did watch it. It's very good.
Dr. Jindal, thank you so much for joining me and spending your part of your day with LTC Heroes. It's a pleasure. If we're ever down in Atlanta, I'll look you up. And thank you so much for your time.
Thank you, Peter. It was wonderful. And I really enjoyed this time. I appreciate you having